think about digital highway. You don't want your car manufacturer to build them. You don't want a GM highway, you don't want a Toyota highway, you want a public highway that everybody can use. So how do we think about that when it comes to our digital and health IT infrastructure? And more importantly, we hear about reactivating or activating services in response to disaster. How do we think about having a system that can serve the population in a time of peace, but be ready and can be used for disaster response in emergency? How do we bridge those two important areas so that it's seamless? Because that's where the technology comes in. And at the end of the day, we need to have a way of managing those relationships, and I think we already heard a lot about that. So with that, I will share with you, and in fact, this conversation began when I was on the panel for the global health, and the same conversation is happening in our global health arena in the underserved countries, even though we have many underserved communities in the US. And it's really the same idea that we need to address these, and particularly, we need to really think about the infrastructure. That's what we're going to talk about today. And there are many other lessons to be learned from here, from the international community. But today I want to talk about some of the recommendations that came out from our committee report to the administration. One more hit. So we needed a infrastructure, a strategy that addressed security, which we know, that allow us to have both surveillance and response. But that's really an emergency disaster thing. But that, and we have seen globally how that we react to it, when Ebola hit and when SARS hit, and domestically through natural disaster, we are not prepared, we react when things hit. How do we think about a structure that actually is ready? And the way we make it ready is how to deliver services in peacetime that actually has value, so that it's right there and ready and can be used when there's a disaster. So the digital health platform that we imagine now need to be adaptable, certainly to globally and domestically to a different community, because at the end it's really about the community. And then what we need to is thinking about creating a framework to allow us to provide our services in peacetime as well as in emergency. Next slide. So this is sort of an idea, and something that we've been building in South Texas. The idea that we need an agnostic, that public digital highway, that allow us to aggregate data. And here we focus on healthcare and research, but certainly you can imagine extending that to social service and to emergency responses, and very sensible way of doing so. But then really, I think the FCC really have pushed this, the idea of build once and use many times, and same thing we should think about that with the data. How do we aggregate that data and use it many times? Use it for healthcare delivery in peacetime and response, such as patients that are connected digitally because we're monitoring them for their chronic disease management, or they are on dialysis machine because that's part of their care. That connection can now be used as a way of knowing who is really at risk when the electricity grid goes out. And those are the people your emergency service have to go first, because their line may be dependent and the battery lasts for 6 hours. So you got to get out there. So that's sort of the idea of really using the data more than once, even though you're aggregating data, maybe not necessarily for the same purpose. But very importantly, the blue box on top, which I'll come back to, it is what I think we want to talk about today. So here is the idea from our South Texas project, is the idea of changing the way we think about the healthcare system to include the community where the people lived and worked. But importantly, create that connectivity so that we have data. And in peacetime, we can use this infrastructure to provide care, and I'll show you an example of that. Next slide. So the project we started in South Texas along the border is to, just keep getting, yeah, that's good. Use it as an opportunity to learn about how to create that kind of connected ecosystem outside the traditional healthcare environment, engaging the private sector so that we can build a community-based healthcare delivery ecosystem where the healthcare data is shared. But how do we do that when we're talking about an underserved population that have very little resource? And we all know that as much as we love to say technology will solve the problem, they are still very expensive. And the people that are at the most need for it is the least able to afford them. So we have to think about how to lower that barrier to entry. So this is the infrastructure, next slide, that went in and we created. The UT system went in as a convener, and that's an important one I want to end today's talk about. To bring both public and private sector together. In this case, I show you AT&T as our telecommunication partner, Walmart as our retail partner, and certainly FQAC as the local community primary care services and some of the cloud service, third-party, medication fulfillment, and certainly patient-generated health data that's really popular in the state. But the idea is that if you think from the perspective of the patient that has the need, it is not really something we want to rely on a health system or a retailer to figure out how to provide a continuity of service. We need to have someone that think about what the patient needs and bring these things together and make it seamless on behalf of the patients. And that's what we did, and importantly, thinking about building an interchange, in this case, using PricewaterhouseCoopers as a neutral third party, who is not part of that delivery value chain, which, come back to the highway analogy, it's important that it doesn't belong to any car manufacturer, to own a segment of the highway, so that we can now have that facilitatory thing. But importantly, figuring out during this process, what are the non-technical things we have to do, which is where the rubber meets the road. Because at the end of the day, we can bring these groups together without trust, but trust needs to be verified and constantly reinforced. That's where the operating model comes in, the governance come in, and ultimately all have to translate into contract, particularly when you're thinking about a small FQAC and a Fortune 1 company. Very difficult to put them on the same playing field, and that's constantly a challenge. Next slide. And then on top of that, we can start building program. In this case, we build program to focus on going out to the community, finding people who needed care. We are starting a retail store, we go to farmers market, we go to the Colonial, we go to churches now, we're in the city's library. The idea is that we can't wait for them to come to us, because when they do, it's usually in the emergency room, and we don't want to see them that way. We want to find them and provide screening, but importantly, create a connection. So this is where, for example, the Lifeline Program is so important. We found close to 10,000 people we reach, 50% have no insurance, and 70% of them don't have Wi-Fi access at home. So now, you can talk about how great your mobile techs are. It's not going to do any good to these people, except for a program like Lifeline that can actually deliver that tool. Otherwise, everything else you talk about wouldn't matter, wouldn't get to these people. And then the other thing that we do is that now, how do we create the ecosystem so that we can have a connection to these people that can share data in real time with other capability. One more. And provide the kind of support they need. Because at the end of the day, whatever you put on the cloud is not going to work. You need to build a community to support them. And the other example is when patients that had complex disease, multiple comorbidity, how do we manage them in between doctor's visit? An example is example would be like the dialysis patient, for example, because that connection allows you to now use it at the time of the emergency. So what we have done, and I'm not going to talk about, we have outcome data showing that we can improve control of the chronic condition, for example. But the question now is that imagine that framework where we can now think about extending that across to public services, disaster response, in a way that at the same time using these technology to be connected to the population and help manage their health, which clearly will be an important aspect as well. And then what I want to really end here is the role of the convener. When we show up in this city, the second poorest county and number 2 poorest city along, in the country, the private industry showing up with the private big company, Fortune 20 company, there's significant trust issue there. And that's where the role of convener comes in. The convener needs to come in and help bring these different players together and manage them. Organization, public or private, do not self-organize. I don't care how well-intended you are, they don't organize among themselves. They needed to have the convener to help manage them, but that management also needs to be enabled. And that's where the common infrastructure. We have to lower the work that it takes to share data, the work it takes to collaborate. If it's hard to do, then it's that much easier not to do it. So we have to have the infrastructure to facilitate, and we need an infrastructure to be tomorrow's digital utility or the public utility of today or yesterday. Because we really need that, and I think there's a role for government to really play a facilitating role there. And then finally, when we are dealing with the Walmart, when we're dealing with AT&T, or even a federally qualified health center or a community health program that's funded by the faith-based organization, every one of them are well-intended, but they all have an objective. And the question is, who's thinking on behalf of the patient? Who are ultimately your stakeholders? Nobody. That's where the convener goes. We need a convener who's going to be an advocate for the patient to make sure that every component that comes together need to be win-win, but have to be win-win for the patient as well. And I see the role for public entity, nonprofit, like what NHIT have been doing in Puerto Rico to serve the convener role, to be able to bring all this organization together, and in this case, not just to maximize and amplify the impact of the federal investment, but also to tap into what the private sector can bring. But to do that well, we're going to need that convener to serve, to manage, and govern on behalf of patients.
Thank you all. My name is Greg Gaga. I am with NHIT. I'm going to be talking about delivery and how we've been talking a lot about the problems and things like that, and the area that I focus on is how do you deliver these public-private partnerships. So one of the things I want to point out first, as I was moved by Congresswoman Stacey Pleskett's talk about build it as it should be. This is sort of core to the heart of NHIT. Our goal in the territories after these storms is not to return to what they were before. What was there before from a health infrastructure wasn't enough. It wasn't good enough. It didn't work. Right? The goal is to return it to something better, what it should be. And I also believe that there's a lesson here for the rest of the territories and also the rest of the United States. There's a unique opportunity here that as we build a true digital infrastructure for health in the territories, this will be a lesson and a good example of how we can even improve our health services. I'm from Virginia, in particularly rural Virginia. So I wanted to address a couple of themes that some of the speakers spoke to because I think they're interesting. There's build it as it should be. The other is there's been a lot of talk about the importance of a health digital infrastructure, and underlying that is data and interoperable structure, and I just want to accent that. I won't continue to talk about that, but I'm just building upon that. The other is the importance of the public-private partnership. You'll hear that a lot. This is extremely important. A good example of this is when I was at the HIMSS conference with NHIT, there was a person speaking from U.S. Virgin Islands from one of their health facilities, right? Not a big hospital, but a facility out in the community. And they talked about sort of the real-world delivery of all of this. And this is what I find, these are the things I find fascinating, right? I think it's simple or oversimplified. You can imagine you hear there's a place distance far away and there's a terrible storm, and you think, oh boy, I hope they can get to the hospital. But the reality is most of the people are getting their services from these health community centers. And this one center talked about, sure, there was day one, and then it dragged on to days 45 and on. But their parking lot would fill with people who couldn't get internet and couldn't get power, and they would hook into the plugs of the health facility just to charge their phones. They would use the internet there to connect with family and say, hey, I'm okay, and little things like this. And this is there's not a vertical here of healthcare that fits so cleanly that you can define. It's social services, it's human services, it's the community, it's connectivity, it's mental health. It's all of these things that these community centers become the lifeline of how these groups survived. And many of those organizations, while they receive federal funds, many are private organizations too, right? So there's this public-private web of how the community leaned on each other to get through these times, and we need to build on that. And part of that is NHIT, right? So there was a theme about convening, and I appreciate sort of you guys hitting on that, because that's where sort of NHIT grows out of as we get into the delivery side of things. We have to convene the people who have the governance and the authority and the funding from government with the people, the 115 plus health facilities and providers in the area, all to serve one group of people, essentially patients, right? And so this public-private partnership that NHIT is putting together in both territories and helping the territories coordinate with each other on some of these shared resources will be, I promise you, it will be a model for all of the United States, including all the territories in the states, to learn from. Some of the way we're doing that, or the key way we're doing that, is we are building a digital services portfolio management team. Now, this might seem boring or simple or something different, but it's a key important missing piece. Because often I found this is true in my public service, whether it's at the federal level or working in the territories. What I've noticed with public services is there's a disconnect between governance and policy, which are usually made with good intentions, and there's usually a value proposition in there that someone passed a law or made a rule, they want to do something well, and the actual delivery that occurs. And there's all sorts of like how that sausage is made, very wonky, boring things. Sometimes it comes down to there isn't the management skills on some level to actually manage the projects, and those things are just given to vendors. Money's just given to vendors for them to deliver something. Sometimes it's acquisition issues, rules and things that sort of go astray within government and public that get in the way of actual clean delivery. And so what is a good clean delivery? Well, good clean delivery is what we're putting together with this portfolio management team, is an integration of the governance and the policy people. They have to roll up their sleeves. This isn't a board where you sit around and say, hey, that sounds great, and here's the vision where we go. This is a working board where you hear the delivery teams at the grassroots level talking about, these are our blocks, this is what needs to get out of the way. And then all the members, that integrated delivery and governance board, which will be operated by the NHIT team, will help to alleviate, well, that's a policy problem. Let's get that policy changed or removed. Oh, this one's a governance one, or maybe there needs to be a new law passed, or we need to make people aware. We have people at all levels ready to do the work. And that's sort of the inspiring side of this is, as we're working with our federal partners and we're working with the local partners in the territory, overwhelmingly, everybody wants to get this right. Everybody's saying enough, let's get this fixed, let's improve it, let's build it, to again borrow from Congressman Stacey Flex, let's build it as it should be and get this right. And so that's our commitment to the territories. We will be insisting on that and pushing for that constantly. So what does that mean? Like, as you get to the grassroots level? Well, you've heard the talk about the Lifeline Program, the Empower Program, and Pulse Program. I'm going to dig in a little bit on each so you have a general, for those who don't know, a general understanding what they do. Lifeline gives highly discounted phone service to low-income people and people in underserved communities, okay? This is incredibly important because if you aren't connected to the digital world, you can't partake in the digital world. And the most affordable and most high-impact services that we're going to be able to deliver in the health community is going to be data-based, right? And that data information is going to come from a digital platform, and these people have to be hooked in. So it's a key federal program from the FCC that's one that's important not only for the territories, but rural areas in the states and other territories. There's also HHS Empower, and this is a program that it's a great federal program. In fact, it's like sort of an incredible common sense program where there's going to be emergencies, there's going to be things that we can't plan on, and when those happen, there probably won't be power. Well, what if you have a health issue that you are hooked up at home and you're fine at home as long as you have power? And there's many that we can imagine, and you can imagine in Puerto Rico and U.S. Virgin Islands going months without power or power going in and out. What if you require a machine to, do your dialysis? What if you require a machine constantly on to take care of you and do these things? So this program actually tracks those patients who have those issues. So in emergencies, first responders know where do we got to go first, right? And this is just common sense data collection and information. And remarkably in this day and age, particularly in the health industry, we don't have access to or collect this data nearly effective enough. And in Puerto Rico and U.S. Virgin Islands, it's even worse so. So we have to focus our energies on that. The other is Pulse. This is a program that ONC, I think, was behind funding, is that correct? And Pulse is...
What's ONC? People may not know what ONC is.
Okay, so...
The Office of the National
The
Coordinator.
Office of the National Coordinator, they essentially oversee health IT for the federal government standpoint. And what Pulse does, and I think they rolled this out in California first, but what Pulse does is, in a national emergency, if a community like California who has health information exchanges, they're called HIEs for short, right? If you have those, Pulse can hook into those, and the emergency responders can get access to people's health records during an emergency. Now, this is incredibly important because in an emergency, your hospital might be flooded, or your community center might be flooded, right? You might be going to a high school to get those services. Well, how do you bring the health records to those services? Certainly, if you have filing cabinets of paper, which is the case throughout the territories, you're not moving those during the emergency, right? One easy way is a digital service that can be replicated and moved, and you can get access to it, and essentially move the filing services so that people can be treated with knowledge. But each of these programs, or federal programs, they are, if you combine them into a health network, a health digital services network, they are a pin drop in the hundreds of services and the thousands yet to be invented that I can't even think of. They're so creative, right? And all of these need that information digital highway, I think that Sarah was referring to, and that you can hook into. And it begins for the territories simply with creating these health information exchanges, right? That's where we're getting started. That's where our focus is. From there, you create a service layer that's a lightweight service layer that's digital, that services and new mobile apps that are being invented and built can hook into seamlessly and eventually self-onboard to. So here you can create a smarter and healthier targeted health services. One thing that I want to add to this is, and one of the things that I'm excited about, because I know it's possible, and I've worked in government and public sector and have done successful delivery like this, and the theme I'd like to add is that the services we build should be world-class. We have to raise our expectations for what U.S. citizens deserve. And this is true not just in the territories, but every state and rural areas. So we should be delivering world-class services. We have that capability. The tools exist. We just need to align that with the proper methodologies. So, I just want to throw a few things out there. What is world-class health service? One, if I'm evacuated from my home ever, I would love my health record to go wherever I go. In the case of the Virgin Islands and Puerto Rico, people went to Florida, and then a new storm was about to hit Florida, and so they went somewhere else. And the majority of, a lot of those people got lost. We didn't know where they went. I would like, if I'm semi-conscious being shipped around the country, I would like my health record to go with me. I'd like to know people if I have, if I have allergies or something like that. And I think everyone should have that world-class service. When I go somewhere and I end up there, I also want what treatment I receive to become part of my health record and return home for me, because I don't know what service I got. I don't know what happened to me when I was semi-conscious. This should be a minimum expectation of health services in the country, and it's not happening. If an ambulance shows up at my house, my daughter has an EpiPen. We've had some scary incidences with it. It's not fun to go through it when you're worried about your daughter breathing. And thank goodness for, it's not an ambulance that shows up first at our house. We're about a block away from a firehouse. So it's a fire truck that shows up. I would like those fire trucks, the people in that fire truck, to have my daughter's health records. I would like them to know coming in the door what allergies she has and things like that. To me, that seems like a low bar world-class health service that should be available. All of these things are based in data, and then I would like to take these data, anonymous data, but understand in a community, and I'd like to see it mapped out. Where are our medical needs? Is there a certain community that has issues like the HHS Empower program, where we know we have to give extra power services to? And there are things we can do to prepare for that. These are just helpful, common sense information things. And the other one may seem like it doesn't relate to health IT, but a healthy community is a working community with a strong economy. And as we have an enormous amount of money that's going to be coming out of the federal government, and it's going to be flowing into Puerto Rico and U.S. Virgin Islands, and as well as Texas, and as well as Florida and some other areas. What I would like to see out of that money is not to enrich the classic Beltway bandits, right? But to actually see workforce being developed in those communities. Because if you want to improve healthcare long-term in those communities, you do it with employment, and you do it with people working, and you build a modern employment center. So we're committed to that. That's one of the pillars of NHIT, and that is all part of a complex, and there's so much more to it, but it's just a world-class health service.
And the Virgin Islands is small, even though we have 3 islands. How did healthcare, were you able to serve the whole island and all of those health centers?
So it's always hard to measure our impact, but we were able to serve many of the clinics kind of through other coordinating bodies. So we worked with Luis and his team and the Primary Care Association on the island to target which communities kind of needed radios, you know, which ones were priority to receive radio access. And once those had radios, they were able to kind of coordinate and aggregate supply requests. And so there was kind of a lot of, you know, rolling up and aggregating of needs rather than trying to service every single island clinic rather. But no, it was very difficult, especially with communications being down. So kind of working, there can never be kind of too much coordination and working with partners on those aspects.
Yeah. Well, one of the things that we did early on, we realized that FEMA had in their database the hospitals from a procurement perspective to issue orders, but what was not in any of those maps were the federally qualified health centers in their satellite offices. So we did, if you go to NHITcare.org, which is the campaign that we launched, we put together an open source map that highlights all the federally qualified health centers in their satellite offices. And you can actually narrow down to the community. One of the advantages that we had on the ground is we have been in Puerto Rico for a while. Right. Personally, I launched the HIMSS Latino community in 2010, so I helped launch the chapter in Puerto Rico. NHIT has been in Puerto Rico, and we had partners, because we work with the Puerto Rico Regional Extension Center, we had partners on the ground. So we teamed up with the Primary Care Association, and through text, was able to get real live information, and sometimes we were able to provide that information to our federal partners in real time. And that's how we teamed up with Healthcare Ready and came together with the Sprint team that was on the ground to get those two-way radios to these centers. We wanted to get satellite phones into the ground when we realized and when they was telling us the satellite phones are not working. Two-way radios are a lot better for us in terms of coordinating the providers that are going out into the communities. So we got those two-way radios together. And then what we realized through another partner that we've had throughout the years in SPEEDA, it was that the mental health issues in Puerto Rico were increasing significantly. So we helped working with Healthcare Ready and Sprint and FEMA. We helped prioritize getting SPEEDA back up and running their 12 clinics and their 1 hospital in Ponce. So
a community that's scared to participate, for lack of a better term, right? So, and yet we need the participation for us to understand the whole of our responsibility for healthcare in this country. In fact, this is true not just with undocumented, but even just underserved communities. There's lack of participation in the systems, and Louise can go into some stories about they don't get counted, right? It's just, we don't know. So the key here, the way you go about doing it, I unfortunately don't have the slick answer because I'm not that community, right? But the people I know or read about in that community, they will seek very local health services, right? So if you think we were talking about health facilities, there's even smaller health facilities out there that may even be a bit off the radar. And I think the angle there is around a patient-centered health services. And what I mean by that is there's a term in the digital services world of user-centered or human-centered services. And what we need to do is flip the value proposition to not be so focused on stakeholders and hospitals and all of these big things that we do with healthcare and the technologies even, right? It's actually to focus on what's the journey of the individual patients and what is it like for them and what is their value proposition. And so what I would say is they are likely receiving healthcare from somewhere, right? And the key is to engage that community in a patient-centered way and figure out how you can engage them with tools that they need that help their health services, right? There's not one app you can build that's going to work for everybody and everyone's going to like, but fortunately we have the ability, we can build multiple ones and do more good.
And I think Dr. Chen, being from Texas, probably can give us some.
Yeah, so I want to ask all of you to, for a moment, let yourself imagine outside the box, right? It's more, I would go even a step beyond what Greg was talking about. It's about thinking no longer providers in the hospital. Think about, or clinic for that matter, or even small health services. Think about patients in the communities. And really think about what's changed in our retail life. Okay, you used to have to go to the store, you think about what the store has. Today you don't have to. You just have to get on Amazon, maybe other website. But the point is, and I always use this, I don't know how many people remember the Landing Tree mortgage commercial on TV. It really struck me. The whole thing about when the bankers come to you, about digital e-insurance, e-mortgage, when the banks come to you to compete for you. That's what we need to do. Now, if you have that infrastructure, which is really what we try to build in South Texas, that ecosystem, which is not anchored on any enterprises. Even the federally qualified center is not the center of it, because it cannot be, because they can only do so much. It's not the retailer. It should not, healthcare should not be in our CVS or Walmart. They should be part of it. So how do you build that really truly patient and community and consumer focused ecosystem? Is served to facilitate so that now the choice is, do you go to FQAC? Do you have a telemedicine virtual care, which is going to be a big part in any of these disaster areas that we have to be able to deliver? And how do you make sure that the consumer, in this case, who is in need of service in the healthcare area, can choose? Because they may have different need and they have different ability to pay, and like it or not, we need to give them the basic that they need, even though it may not be the best that one can get, because we can't, not everybody can get the best. That's the reality of the world. So it's how do you build that ecosystem so that you turn the whole thing around? It's all going to be about the patient. So I would say, in this territory, yeah, the FQAC need to be connected, and they definitely are. And when it comes to, actually the question is about trust. So the experience there is that if you have the infrastructure in the background, which is the enablement, then your community health worker becomes the front line. They are the one that, whether they are uninsured or they're undocumented, they are the one they trust. They don't even trust the doctors or the nurses. They trust the community health workers. They can align them, but the community health worker needs to have the capability to help guide them to these capability that's cloud-based, that come from, that's not limited to what's available locally. So I think the ecosystem that reach these populations need to be the hybrid. You have that agnostic, sort of, in some way, very technology-driven capability that deliver 80% of it. And that last 20% need to be in the community and is optimized or tweaked for the populations there so that you have the right people. So what we have to build is not just the capability, is the service layer, but actually is a human layer that you have to build that connect to the service, connect to the technology, because without all three layers in place, you're not going to touch these people. So that's really, to me, I think there's models out there from other industry that clearly have worked. We've been experimenting to try to think about how to evolve that to add what healthcare needs, because healthcare is very different from commerce. But there are a lot of shared lessons that we can learn and a lot of capability. But I do come back to the point where I mentioned, you need a service layer that bridges the gap between the intent and the delivery service. But that needs to be based on actual local human hands at the end of the day. It can't be remote.
And as you say that, the last time I was on a panel with Nicolette, we were talking about some of this, and there's always been a CERT, Citizens Emergency Response Team or something like that.
You got it.
Y'all have those in your community? There needs to be one that's for, or at least they need to be trained in health as well, so that those people would be your community health worker type folks that would be already in the community, have some knowledge about who's there and what the healthcare needs of the community that they're in. It's just something that I think really needs to happen, that we need to beef up those CERT teams and also have them trained in at least basic disaster response.
I think is trained and also real-time support, because they can't be trained on everything. But if you have connection and they actually have back end has technology to support them, you can give them the instruction, you can give them just in time, knowledge so that they can react. And then the other thing I do want to add in terms of the trust issue, which I hinted at, in my presentation, there is value to have a neutral party. That's not the government, that's not the state, as the provider. So one of the things that actually helps a little bit, doesn't solve all the problem, in terms of sharing the information is, the information, for example, in our project, doesn't go to any state, federal law, any entity. It is a neutral, for-profit, if you want to think about it, private industry that sort of is a service they provide. And there are pros and cons to that, but actually it does, especially among the undocumented, it has a certain advantage to be able to present that to them.
One thing I want to add, which is the point she was bringing up, the term is now used Industry 4.0, just from a technology standpoint, that the world is, we're now in like a fourth industry. And we designed our healthcare services a long time ago as factory models. You go to a hospital and you go through the factory, right? And even the healthcare centers that you're referring to are factories and things like that. We're actually returning, because the technologies have come down in price so much, and an individual with some pieces of equipment can perform all sorts of tests and do all sorts of things. The prices have come down, we've returned to cottage industry, and what you're referring to is today as we speak, there's a return to people visiting homes and being in the local community and checking in with people with amazing technologies around them that allow them to do things they couldn't have done years before.
Hopefully not cottage industries.
I'll go to in the back and then I'll come to you.
Well, I just want to say that we have the Medical Reserve Corps, which is the medical equivalent for volunteers. They're throughout the country, hundreds of them, usually linked to local and state health departments. And Pulse, I know, has a system for linking in volunteers, including Medical Reserve Corps, and giving them access to medical records. So I just wanted to let people know that the Medical Reserve Corps is out there. Also, many people will go to free clinics, and more free clinics have electronic records linked to systems. And so linking in free clinics would be another mechanism. But the MRCs are just fantastic, and they're throughout the country.
You need to start one in the Virgin Islands, yes, sir.
Yeah, I haven't heard the term, one I want to say, I've really been impressed by the quality of the amazing work that's been done by healthcare already, by the nonprofits, and just the way you mobilize communities and done amazing things. I haven't heard equity talked about as much in this discussion. I mean, a little about how Guam is so far away and it gets ignored, but what I haven't heard talked about is, like when Irma hit Florida, hit Puerto Rico, hit Florida, in a lot of places, it seemed from what I could tell, there was a great ability to mobilize resources to sort of minorly inconvenience people with generators and people in wealthier communities that, well, maybe their cell phone wasn't working as well as it should. Maybe they had run on generator for a few days. There's going to be an ability to mobilize resources to that. Well, people that were dying and flooding and didn't have those kind of resources, didn't have those connections, couldn't get the resources. One pet theory. If there was a bill saying you can't get power restored or Comcast restored to your house on in Palm Beach until these other people have power, they would have power in a day. That was the bill. But are there systemic ways to start thinking about that and even to measure that in responses and to do something about pointing it out and taking action on it? And am I right in seeing that as an issue? I think
No, absolutely. No, absolutely. And no, I'm glad you bring it up, and it's something that we've been working at a lot, even not just in response plans, but in kind of preparedness and resilience initiatives and efforts as well. And I think you see it, I think there's themes of it in some of these conversations, and it takes it to a couple different forms, whether it's medically fragile populations, vulnerable populations. But unfortunately, I think last year really underscored for us that health equity needs to be prioritized much more in planning, and I think and we're doing this as well as kind of an education issue, like what health equity even means and is, and why what the allocation of resources looks like for that. You can't do equal distribution of resources because that's not an equitable distribution, and so kind of communicating why that has to be when there's usually limited resources for a disaster. So no, it's something that I know our organization and many others at the table have been working at.
And I think Congresswoman Plaskett touched on it, and so did Congresswoman Bordalio to some extent. If we're not getting equal resources or equitable address to our need for resources in good times, we're not going to be ready when a disaster hits. And they have to take into consideration, one, we don't have a grid that is connected to any other place. When our electricity is down, we can't get electricity from the next whatever. Everything that comes in has to come, everything that we have can't be brought in by a truck. It has to be shipped. So all of those things need to be taken into consideration to make sure that we are treated with equity when we're in need as well.
So, one of, Josh, this, you've been to the Wall Street Summit.
Yeah.
One of the things that we do as an organization, we talk about two things, and why we have the Wall Street Summit. When you think of underserved communities, a lot of folks are thinking of underserved communities from the consumption of health. Take care of your diabetes, take care of your hypertension, right? What they're not doing is talking about the production of health. And what we need, and Greg alluded to this on earlier, what we need to make sure is that in this $3 trillion business of health, that underserved communities are part of the workforce, are part of the innovation, are part of the decision-making process, right? And what that will do, by default, is we will be at the table making sure that those decisions are being made, right? So I point that out because, as Donna just mentioned, during the disaster it's just magnified the issue, right? But we're dealing with inequities in underserved communities all the way, right? So what NHIT has done, we have been focusing on what the future looks like, what's the innovation look like, the positive aspects of this, right? But by no means are we neglecting or ignoring the facts of these underlying social impact issues that are impacting these communities.
And I want to add to Lee's point, and I think Greg mentioned, right? We don't want to just rebuild to what it was. It should be rebuilt to world class. And I do believe that it is an opportunity to do so. The opportunity to do that in an underserved community means the opportunity of bringing the best to the community that typically do not get the best. I often have been asked by many people why I chose South Texas to do the project we did, and why we should bring in these national and global entity. And well, it's because those guys do have a lot of resources, and they do, work on the cutting edge stuff, and they will never go to a community like in South Texas. They would only go if the Convener dragged them there. But if you get them there, give them reasons to go there and build something that they actually can imagine working, we don't have to worry about them taking it to New York City. But if we're building in New York City, you're going to have a hard time getting them to bring it to South Texas. So I think this is, in some way, the disaster and the disaster funding is an opportunity. The rebuild opportunity is the opportunity for us to build something better than the rest of the country, so that it is a model, because that's the only way to lift the community above, rather than just, making up for it. Question in the back?
I'm sorry, I usually eat at noon, so I'm getting a little delirious.
Okay.
It's like, what's going on? I'm going to try to answer the two last questions from a different perspective, which is from the citizenship status. Federally qualified health centers in statute are open to all regardless of ability to pay. So every time any of the panelists mentioned the FQHC side of it, we worked with Healthcare Ready and Louise and everybody else to help Puerto Rico, and it was, to be honest with you, a little bit easier because there's a primary care association that gets to the 20 FQHCs and the 90 sites and the island as a whole from the FQHC perspective. And then you go to Virgin Islands and you ask, okay, how do I help the FQHCs of the Virgin Islands? There is no PCA, there is no primary care association, there is not, that infrastructure isn't there from an equity perspective. And so, and Guam, there's no American Samoa, Mariana Islands, Guam Primary Care Association. You have to do this all one-off, one-off, to try to help in these disaster situations. HRSA, the people that fund the health center program, have the ability to say, I'll fund a PCA that helps these, that lets this coordination occur amongst the territories. I went to the Virgin Island Health Centers and said, why don't you just, we're doing stuff through the PCA because they have it in Puerto Rico. Why don't you do stuff through the Puerto Rico PCA? And they said, well, to be honest with you, a lot of their stuff is in Spanish. And we speak English, by the way, so in the Virgin Islands. So it was hard to get a lot of the different things in the coordination of activity. But your question was specifically on equity, and that goes to the infrastructure that's there.
Add with HRSA. But I think that we see another PCA in the room. But we should look at how do we help strategically and push for that. And one of the things that we recommended is doing an MOU between Puerto Rico and the Virgin Islands. But it is needed. You're right.
Something, anything.
So can I add one point on the equity piece? And it doesn't replace all the things that's been said, but I think technology is a great tool for equalizing access, and it is certainly a tool for equity. And we have seen how cloud-based services like the AWS of the world sort of provide equitable access for many to a piece of technology. So I think in addition to all the things that's been talked about, and I emphasize how important on the ground and being connected are, but I want to come back to that digital infrastructure, because that is the cloud infrastructure that allow us to level set and make more equitable the potential to access technology. Because I've seen it in South Texas, which is not even an island, and you can drive there, you can fly there, but you're talking about people who could not afford a phone or who didn't have Wi-Fi access, and an FQHC who did not have the resources to figure out how to do remote monitoring because they just can't afford to. The way we did it is by offering them one connection, which opened up an entire marketplace of solution to them. That kind of infrastructure is how we create some level of equity in terms of technology. So I think of the ecosystem platform I talk about as a AWS version, the cloud versions of healthcare service that layer a lot of the additional capability that's necessary for healthcare delivery. And then now, on top of that, if local community team, for lack of a better word, can now build it on the ground community that's needed with the association and so on, but being able to tap into that kind of infrastructure is one way for us to think about at least addressing the equitable access to technology piece.
And one important access to technology is the Lifeline Program. And it currently serves more than 12 million Americans, including at least 6.5 million who access internet service through the program. And it is at risk. And maybe Luis, you would want to just say a few more words about, before we close, about Lifeline and any other closing comments.
Yeah, just in general, I think we need to continue pushing this theme of leveraging those federal investments and those federal solutions as much as possible. And then continue working with our private sector partners. But let it be no mistake, our entire underserved community ecosystem is currently under impact, is currently under attack. Whether it's Lifeline, and there's a void nationally on underserved representation when it comes to health. So keep that in mind. There's programs like Lifeline that are literally a lifeline to these underserved communities that allows individuals to text their providers and engage and communicate. And right now we're talking about eliminating that at a time where we're in another hurricane season. It makes no sense. And so from a national perspective, as the National Health IT Collaborative for the underserved, representing underserved communities, that is something that we're going to continue keeping an eye on, and we're going to continue pushing for, because I believe we should be leveraging these resources to make sure that our underserved communities have the resources that they need as we move forward.